Good afternoon, Team UHN, and welcome back to our virtual open forum. I want to apologize for starting about 3 minutes late. My fault. I apologize again. As you know, these are very stressful times, and we're hearing some very worrisome news, particularly around the growth in positive numbers and of late in the growth in hospitalizations and ICU utilization in parts of our city and province. I do, however, want to start on a more optimistic note today, and that is looking to the science of Pfizer and Moderna. And I think there are about 9 vaccines under development, but we've seen phase 3 trial results for 2. Both are over 90% effective at preventing the virus. We heard yesterday Moderna speaking of a 94.5% efficacy. This really is a tremendous achievement on behalf of our scientific community, virologists, and those who will then manufacture these important vaccines. And it is a light at the end of the tunnel, but it's not a panacea. We know that with the distribution and inoculation, we still will have to struggle with ending this pandemic and working hard to ensure that we continue to be compliant. And we're quite a long way off from its distribution to any and all. So more important than ever that each of us at Team UHN really continue to follow the rules, both at work and when not at work, around physical distancing, only socializing with those whom you reside, effective masking, covering one's nose and mouth, and of course, all good public health hygiene around hand washing. We also know that the next few months are going to be challenging. So while we don't have a significant flu outbreak yet, and we hope that we won't, as the Southern Hemisphere did not, we do know that we are starting to feel very significant challenges in numbers. And for those of you who saw Dr. Brown on the Premier's briefer the other day with the press, at a 5% growth rate, which is approximately where we're at, if we don't change the trajectory of this by our own behaviors, then we would see over 6,000 cases a day in the coming months. And that would obviously overwhelm the healthcare system for the subset of those who would require hospitalization. So my strongest plea is to you and your families to really truly follow the rules. And if any of you are not doing so in your personal lives or see others, please encourage them and your families to do so. We have multiple COVID-related agenda items today, and I'll just mention a few. A status update on the overall trends from Dr. Hoda. A system update on what's happening in our broader healthcare system as a response to COVID numbers. A work-from-home update from our HR leaders. And a clinical activity ramp down, should it be required, by Dr. Qureshi. And of course, our important question and answer session. So I think I'll turn it over to Jill.
Okay, we're going to start with Dr. Susie Hoda today. Susie's going to give us an overview of COVID. And Susie, maybe some comments about flu and the flu season.
Thank you, Jill. So as you'll see on the current state slide that's up, we've surpassed the 300,000 case mark within Canada in terms of COVID-19, and 100,000 of those cases approximately have arisen in the last month. So we certainly are on a trend, speaking to what Kevin's outlined in terms of updated modeling numbers as well for the province, that we are not happy to see. And within Ontario, we're having about 1,500 new cases per day, with about 500 of those new cases occurring within Toronto. And the Scarborough area within the Toronto region, as well as Peel region, are 2 hotspots that are very heavily affected by COVID-19 currently. So everyone's watching this very, very closely because we know what happens in the areas surrounding us that may affect us soon as well. Here within UHN, we currently have 16 cases of COVID-19 within our hospital, 8 within the ICUs, 8 as inpatients.
Oh, Susie, you're breaking up a bit, I think, if you're on the phone, on a cell.
Second wave. But certainly if we don't really buckle up and start working hard on our physical distancing and masking and reducing our overall contacts in the public, there are concerns about hospitals facing significant surges of cases. So I'll just pause there.
Yeah, and I guess just to complement Susie's comments, we know in Peel and in Scarborough and in Mississauga that that's already occurring. And we've had to see a number of patients transferred out, particularly to date of Peel, but I'm sure that won't be the last. We've put in place with Ontario Health a IMS structure for the management of acute beds in the event of movement required, and we can talk a bit more about that later. But obviously, we're entering a very fragile period and a period where we may have to make very difficult decisions again about scheduled care.
So the next topic on the agenda is working from home. I think it's fair to say that given what we're talking about here, the rising cases, we also need to look at this from a UHN perspective. Obviously, masking, physical distancing, and hand hygiene are important. We're also looking at unnecessary in-person traffic at UHN as another part of that strategy, and that means avoiding in-person meetings unless they are absolutely necessary. It also means working from home if your physical presence is not required. Diana Elder is going to talk a little bit more about that work from home policy. Diana.
Thanks, Jill. So, I think that it's quite apropos that Susie is giving her update and talking about.
Diana, sorry, we're not getting a very clear signal from you. I'm not sure if you're on a cell phone.
I am on the phone. Let me see if I can get to a better place.
Clearer now, but we may have to continue to. But it's us guys. So
okay.
Somehow it's us guys, Brad tells us, whispering from the wings. So I'm going to ask my trusty colleague to figure out what that means, because I don't know how it's just the phone we've normally used. Are we using, is that our normal process of setup?
Yeah. So try again, Diana.
Can you hear?
Yeah, can you
hear me now?
Yep.
Okay, excellent. So as I was saying, I think that it's quite apropos that Susie gave us an update about what's happening in our community in terms of the number of cases rising. And so wanted to just emphasize, again, I know that we have been saying that for individuals who can work from home or have been or should continue to work from home, as we try to lessen the traffic within the hospital and keep everyone safe. So we want to use our regular protocols around speaking with your manager to ensure that there's agreement around when that can occur. And also, I know that many of us have started to do more of a hybrid model. So we may want to look at whether or not at this point it makes more sense to work from home, to have more days working from home than perhaps we may have had in the past. I just want to also reminds us that we are looking at a more robust, longer-term remote working strategy, and that is still in the works. And so we'll be providing you with an update on that when we have more information.
So Diana, there are a lot of questions today. We're not yet at the questions, but a lot of questions today about work from home and a sort of I guess an overall flavor that there are some areas where the manager is really not that keen on it. So can you maybe talk a bit more about that?
Yes. So I think that we've been thinking about what an escalation process might look like, and I believe that if your manager, if you sincerely believe that there's an opportunity for you to work from home or that your role can be done from home, that we should be using our typical operational escalation process and speaking with your clinical director. Certainly, you can also reach out to your HR contact person to talk about, how you might approach that conversation, or for support in that conversation. Also, we'd be happy to help.
Okay, thanks, Diana. Kevin.
Yeah. So Diana, do you have any idea when we'll hear our next update on work from home policy? Like, what's the time frame for that?
So, Kevin, it is actually coming to ELF on Thursday.
Right. Okay.
And so I would think probably for our next open forum, we should have some updates.
Okay. The second piece, again, so just to be very clear, if you think there are opportunities to work from home and you feel that you deserve an appeal mechanism that you're not being granted, go to the person to whom the person you report to who's denied the opportunity, go to the person to whom they report, and that'll get escalated up the chain. We obviously want to support as many people working from home as possible, especially as we see numbers as scary as we've heard with the 5% growth rate. The second piece, and I really feel badly for saying this, the holiday season is upon us. Last weekend was Diwali. We have Hanukkah coming up, Christmas coming up, the celebrations of many faith groups and times when families choose to get together. And normally at UHN, I think one of the things I'm very proud of is that we're an environment that embraces and celebrates those things. But this year, we have to ask you to avoid doing so other than virtually. And while we'll talk more about what some of the ways we can celebrate collectively and individually, please ensure that you're not having any gatherings to celebrate the holidays physically in your areas or units. And I really, again, want to tell you how badly I feel saying that, but that relative to the risk of your becoming ill or our patients becoming iller, unfortunately, that's the place we find ourselves this year.
It's a really tough message.
It is.
I'm going to turn next to Dr. Fayez Qureshi, who's the executive sponsor for the Clinical Activity Recovery Team, and he'll be talking about the Clinical Activity Ramp Down Blueprint that was finalized for UHN last week. Nobody wants to ramp down, but in the light of the growing COVID numbers, it's essential that we have a solid plan to do that if we have to. So Fayez, over to you.
Great, thanks, Jillian. And I think it is apropos that Susie gave the presentation at the beginning of this session, outlining some of the increasing numbers in the community. And as you said, Jill, our priority is to serve all of our patients to the best of our ability. And likewise, being able to have a plan prepared, should it be required, is something that we feel very strongly about. So I'll start off by just sharing what's on this slide in front of you, that this clinical activity ramp down blueprint was developed really through an interprofessional team across all programs at UHN. There were representation from clinical leaders, clinical directors, program medical directors, and importantly from our bioethical team, as well as from patient partners and essential care providers. And so they really helped us shape the decision-making around looking at activity should we require to see some reductions. This team was led by Barry Rubin and Terry Stewart McEwen, with strong support from Jenny Catton and Jessica Marangos, and thank you to them for their leadership in this. Ann Heesters and Jennifer Bell used an accountability for reasonableness framework to help walk us through scenarios and scenario testing should activity be required to be reduced. Now, I'll say different than the first wave where we pulled back activity uniformly across the enterprise in all care provision. This is a different scenario. We've learned a lot from phase one, and we recognize that there are inherent differences between programs. And so in the blueprint that we've articulated, should it be required to be used, reductions will not be uniform across all care types or across all programs. So what that may mean is that some areas where UHN plays a very specific role in the province, as in lung transplantation, critical cardiac care, neurosurgery, and others, we may retain that activity level at a higher proportion than others where we may be one of many in the region that provides that care. That doesn't mean that any work is less valuable than others, but we're recognizing that we play a unique role among some of our partner institutions across the region. In terms of triggers that we would use to help move forward with the blueprint, there are a number of variables, and we're leveraging the current huddle structure in the organization, where we're hearing right from the front line during our daily unit huddles, and that percolates up towards the network huddle about concerns across the enterprise. And some of the key pieces relate to PPE, staffing, critical medications, bed capacity, both on the wards as well as in the ICUs. And all of those variables together help to bring forward certain triggers that would tell us now may be the time to pull back some activity. You may be asking, well, why would we have to pull back activity if we had to? Well, there are a number of reasons, and some of the ones have already been articulated, but really maintaining staffing flexibility, maintaining capacity in our ICUs and our ward to care for the sickest patients, be they COVID or non-COVID patients, and also decreasing potential exposure to staff and to patients. The comment was made earlier about just decreasing foot traffic in the organization or gatherings, and that also applies that as the community levels increase, we want to make sure we're being mindful of who comes into the organization for their care. The bottom principle, of course, is that we'd like to retain activity as long as it is safe to do so, and that really is a commitment that we make to our patients and to our staff. We've also put forward an ethical decision tool that can be used by different teams at the point of care. It was articulated by our bioethical team in helping to provide a justice-based framework and making timely decisions around resource allocation. We've distributed this, Kevin and Jillian, to all of our program medical directors and clinical directors to be cascaded to managers. And should any of our staff have any questions about how to use the tool, please do ask your respective managers for this as well. I just want to close by reiterating our promise to our staff and to our patients that we do want to provide the highest quality safe care to all patients that UHN cares for, be they patients with COVID or non-COVID or requiring specialized care, and that also staff wellness is of key importance for our teams, that we want to make sure that we're providing you with the tools to take care of yourself and to take care of one another, and that we have wellness resources available through our HR team, as well as respite services as well to help you. So if there are any questions at all about the ramp down plan, I would encourage you to speak with your clinical director and program medical director, or by all means come and chat with me. I'd be delighted to speak to you about it, or Terry or Barry. Thanks, Kevin.
Thank you. Fayez?
So, nobody wants to get into that situation, but it's good we have a plan to do it.
Yeah, absolutely.
Okay, we're going to move to our regular question and answers, and I think actually the first two questions are really about the same, so I'm going to read both of them. And Susie, they're for you. Dr. Hoda, we were told by your department that although COVID patients generate aerosols when they cough or talk or breathe, surgical masks are adequate protection with 98% filtration. Is this misleading? Their actual filtration is much less than 98% due to the gaps, and were never designed for inhalation risk. The second question is about PHAC having recognized aerosol transmission of the virus that causes COVID. How will UHN be changing its policy? So maybe you can talk about aerosolization and the protection of various masks.
Sure, thank you. So Public Health Agency of Canada did indeed update their, recommendations or I guess guidance around how the SARS-CoV-2 virus is transmitted not long ago, just a couple of weeks ago. And following suit of the WHO and the CDC and other agencies, they have recognized that under certain circumstances, aerosols that contain the virus can be generated. And that can include coughing, talking, breathing, singing when somebody is infected with the virus. But the relative importance of aerosols versus droplets versus contact precaution, the contact route of transmission is still somewhat unclear, and we're learning more over time. So I'm sure there will be further updates as we get more of that information. And what that led them to doing is really placing a new emphasis on the importance of assessing ventilation within buildings as one of the measures to prevent transmission of COVID-19. And this makes sense because the epidemiologic data really points towards people being in indoor spaces for prolonged times, in close contact with one another as being the main way that people are transmitting the virus from one to another. And so how does that translate to our hospital environment? And coming back to that first question that was asked, our hospital environments generally have very good ventilation and better than you see in many other indoor spaces. And so, we may be in a slightly different position that way, which is excellent for our ability to control transmission within our walls. And so the sort of the ventilation system of our hospital is something that we are continuing to look very closely at. And we've talked about this. I've talked about this in previous open forums. We're continuing to do work to optimize what we have, to assess and make sure we're on top of what needs to be in place for us to maintain the highest standards possible in our buildings with the ventilation systems. In terms of personal protective equipment, there's been no recommendation to change the way we manage routine care of COVID-19 patients through the Public Health Agency of Canada. So the recommendation here at UHN, as within the rest of the province, is still to use a procedure mask and eye protection as well as a glove and gowns when providing routine care for patients who have COVID-19. However, if you think you're going to be in a situation where you're going to generate more aerosols, a higher concentration of aerosols because of something you'll be doing in the room, and we refer to those as aerosol generating procedures, then you would be wearing a fit-tested N95 respirator. And we know through a lot of assessment that's been happening in the PPE working group we have here at UHN that the surgical masks or the procedure masks that we use for clinical care at UHN do have excellent filtration efficiency. And so the number that was quoted in the first question about 98% filtration efficiency, that is valid for the types of surgical masks that we use. However, it's a secondary issue that somewhat unrelated to that, but still relevant, that when you're wearing a surgical mask, there are gaps. It's not a complete seal around your face. What we have learned over time in using this PPE is that it still remains protective in the routine care environment. So I think that answers both of those questions, and I guess I'll just leave it there.
Okay, thanks, Susie. Kevin has...
Yeah, maybe I'll just make a couple of comments. So not unlike round one, UHN unfortunately is not in a position to act unilaterally. We need to hang together with our advice from public health as well as the advice of the collective TASN hospitals and broader hospital community. What we all worry about is the overuse of N95 masks. And if we were to see the kind of numbers we opened this discussion with, up to 6,500 positive cases a day, and the concomitant needs of hospitals to treat a portion of those people, what we are trying to prevent is us not having those for the true aerosolizing medical procedure should that occur. We are working really diligently with the province and beyond to make sure that we have more than adequate supply of N95 respirators, and we've done very well so far. But we do have to be cautious around the kind of numbers that may be coming down the pipe later on, and how we protect those of you who are caring for patients at that time, as well as currently.
Okay. The next question is really, I think, John Granton and Tamara Deuce. Can you please post on the intranet the accurate and up-to-date number of staff known to have tested positive? Occupational health is notified of all positive cases. Staff deserve to know. The 132 that continues to be posted is meaningless. Please post total numbers regardless of where tested. So John, maybe you first, and then Tamara.
Sure. Good. Thanks very much, and happy to address this. I know this is an area of importance for Team UHN, so happy to speak to it. So there's two components of this. One is the numerator, the number of people, employees, physicians, et cetera, who are testing positive. And then as well, there's also what we compare it to, or the denominator, the total number of people who are being tested or who are potentially could be infected who work at UHN, also in the community. So a couple of things. First of all, the number of people who are infected, and the person who submitted the question is correct. We know the number of people who are testing positive. It's a little more challenging for us to get that number, but you're right, we do get it. Previously, we got it from internal sources because we tested within Occ Health. We now, and then in the first way, recognize that people are tested elsewhere at other CACs, whether it be at the Toronto Western or closer to us at Women's, but also closer to home. And we do access that, but we do rely on the employees to provide us that information very often. We also recognize that it's a bit challenging to put that into context because several of Team UHN work at other sites as well, and to attribute the infection to an employee who works at several acute and maybe some chronic or long-term care facilities can be a bit of a challenge. We also recognize that there are learners that move in and out, and so the numerator, the top number, the number of people infected, can be a bit difficult to sort out and put into context. The more important thing, I think, is also to consider the denominator. What are we comparing it to? Are we comparing to the number of people who have been tested or the number of people who are work across our organization? And I think that's where it really becomes important to put this whole thing into context. We also recognize that not only is there, unfortunately, potential exposures at work, in the work environment, but also in the community. We certainly recognize in areas, and Susie attested to this before, that there are very high community prevalence, up to 19 or 20% in some areas. And so it's sometimes very difficult to determine where individuals actually acquired their infection from. And what we're really want to provide this data, but we really want to provide it in a meaningful way and help people understand what those numbers mean. And we do agree with you that it's important to be transparent. It is important to have accurate data, and we will strive to provide that information for you, but just to make sure that people understand what that number actually means and the limitations of that number, irrespective of what it is.
Okay, Tamara, do you have anything to add?
No, that was great. Thank you, Dr. Grant.
Okay, the next one is for you, Kevin. Dr. Smith, why is there such a discrepancy between what medical experts in the media are recommending and how the provincial government is responding to the second wave? Is the table of advisors recommending something different, or are Premier Ford and Dr. Williams rejecting their recommendations?
So there are many advisory tables, I should mention. I myself and Jill have the privilege of sitting at some. Many people from UHN would be involved at some advisory tables. And I don't think that there's been a rejection. I think what's occurring is a great variation across the province. So while we see, massive growth, for example, today we had some discussion about what's happening in Scarborough, previously in Peel, also in Mississauga area and in downtown Toronto, it's a very different picture in much of the province. So I think part of the confusion is, how do we address small area or small region variation, and how does that then bleed into a public policy agenda? Premier Ford, in my experience, has been very attentive and open to the advice. I will say, not unfamiliar to any of us, medical advice is not always completely consistent, and so when you're left with a lack of complete consistency, then there are debates about what the best opportunities and options might be. Don't forget, the Premier is also hearing very, very loudly from people who are being very negatively affected economically, be that frontline workers who feel frightened not to go to work or to get tested because they wouldn't get paid, or large businesses who've now seen their revenue reduced for such a long period of time, they fear they'll never be able to reopen. So I think everyone is trying to do an excellent job in this initiative. The challenge, of course, is trying to balance the issues of medical care and risk against a rebounding and recovering economy in the longer term. There's good dialogue between the city, through Mayor Tory, the Premier, through, of course, Mr. Ford, and the Prime Minister and Deputy Prime Minister, Mr. Trudeau and Ms. Freeland. So I don't see a great gap between our political leaders. I do continue to see very significant and differing interpretations, both by region, by some professional groups, and, of course, between the balance of the economy and medical protection. Do you want me to combine the next question with this one?
Yeah, I think so, yeah.
Jill? So I also see the next question says some GTA hospitals are taking the Ontario government to task. I don't believe that that's the appropriate approach, to take the government to task. I think that if we are privileged to be at a number of the tables and to provide advice, and the media is not the place that I choose to exert my voice or authority, if I have any. I don't have any authority with the Government of Ontario per se, but I think that it's more important for us to provide reasoned, objective, research-oriented information to the government and volunteer to help them with implementation. I can assure you that I and my colleagues are very vocal with the government about what we think government needs to do and how quickly we think they need to do that. Sometimes government takes our advice and other times they don't. I don't actually believe that the way to adjudicate this is in a got-you approach with media. And so I haven't done that in my career to date, and I'm not going to start now.
I think the thing that I always think about is it's advisory, not decision-making.
Right.
The government makes the decision based on the advice that they get, and they will be getting conflicting advice. And also, the point you make about people's lives and livelihoods, they've got to balance that. So it's a tough job. Dr. Smith, you say you will keep UHN staff safe if they are deployed to long-term care. Dr. Tam is now advising 3-layer masks for public, yet long-term care is still giving level 1 masks to staff. With the huge rise in patient and staff infection rates, we need to care for our seniors and staff with proper PPE in long-term care. And Susie, if you have something about that, perhaps weigh in, but Kevin, if you can start.
Yeah, so I'll let Susie start off because I think there's a misconception about our masks versus a 3-level cloth mask, which a 3-level
yes,
cloth
that's
mask.
exactly it.
Yeah.
So the level 1 that we use in describing that type of mask, it really just does not refer to how many layers are in the mask. It actually, in the mask, it's really referring to how it was designed in terms of the ability to protect against spray in, say, an OR setting or in a clinical setting, rather than talking about, how many layers of fabric are in there or fiber in there, or what kind of filtration efficiency it has. So you can't compare a level 1 medical mask to a triple-layer fabric non-medical mask, which is definitely not designed to be protecting for filtration to the same degree as what you would see in a clinical setting. So the advice that Dr. Tam is given in terms of how we should be designing our non-medical masks for public use is not at all relevant to what we use for PPE that we procure within the healthcare system.
Yeah. So I guess just to continue with that, obviously we look at any time we are asking, and to date it's been voluntary to go to long-term care for support of homes. If things get worse and we're required to deploy involuntarily, then obviously every time we go into a home, Dr. Hoda and her team do an IPAC assessment and ensure that any member of Team UHN who could be deployed voluntarily or otherwise has the appropriate PPE. And again, we do so with our group of TAS and hospitals. I know I say this all the time, but I just want to continue to reinforce it. UHN can't and doesn't act alone in making these decisions. There are public health tables and there are tables around procurement and supply chain that require us to act in concert with our peer hospitals. And while at times that can be frustrating, the good of the many is really a very important theme in a pandemic.
So the next question, I think there are parts of it for Jan and Joy and Diana. Acute allied health remains overworked and understaffed. Can senior management please explain why this group continually gets overlooked in your budgets? There's a reason everyone keeps quitting to go to other hospitals. So Jan or Joy or Diana.
Yeah, happy to. Thanks, Jill. It's Jan Newton here. I'm actually going to ask whoever's put this forward to contact me or
Oh, you're cutting out, Jan.
I really need to understand some specifics on this one. I thought we'd address some of these issues, but we're still missing the mark. So could you connect with me directly? Janet.Newton@HN.ca. Is that right?
So
Thanks.
Jan, unfortunately, either we or you are breaking up a bit, so I'll just summarize what I think Jan said. Please contact her, the originator of this. I guess just for maybe a point of correction, many of our staff in allied health are long-serving, so the assumption that everyone is leaving, I know that's not true, and I would hope that will never be true. I know many groups for sure are feeling overworked and understaffed, allied health amongst them. And Jan and Joy and Diana have been looking at what can be done within the current budgetary environment. One of the challenges, as you all know, is do we hire more people or do we pay the people we have more money within a collective agreement environment? And all of those options are being considered and some adjustments are being made. But if you don't mind contacting Jan, and as she mentioned, it's janet.newton@uhn.ca, the originator of this question, and she can communicate with any who'd like some further detail.
Okay, the next one I think is for you, Diana. Before I read the question, there are a lot of questions in our list today where the answers are available on the intranet. There's this COVID toolkit that Occupational Health has put together. And also, I was looking earlier, there's information on the HR site that talks about how a sick day is coded. But I'm going to go to Diana. Just for clarification, as a full-time employee who tests positive for COVID, will I be paid sick time? The second part, if I am exposed to COVID as a full-time employee and told to stay home by Occupational Health to isolate, even though I test negative, will I be paid sick time or leave for the time I am told to isolate? Diana.
Thanks, Jill. Okay, so the answer to the first part is that if you are a full-time employee and test positive for COVID, yes, you will be paid sick time. With regards to the second part, if you are exposed to COVID and you're a full-time employee and told to stay home by Occupational Health, if you've been exposed within the hospital, yes, you will be paid during your isolation. If this is the community acquired, then you will not be paid. And in this, I mean, there's some other questions I know coming up around this, feelings about this not being fair. But as we've, articulated in the past, this is kind of the stance or the position that's been taken across the TAS and hospitals around sick time and paying for individuals who are testing COVID negative. And so we're not at liberty at this point to change that decision, but we'll continue to lobby to have the COVID pay that was in place during Wave 1, which allowed us to pay for these absences. So we'll continue to lobby for that, and if that changes, we will certainly change our practice.
Okay, the next question, I think part of it for Susie. Is it time to revisit expanded surveillance testing for healthcare workers? Recent study on Marine recruits, and I assume that's in the U.S., recent study on Marine recruits found multiple transmission events despite strict measures, masks, distancing, activities outdoors, enhanced cleaning. The authors noted scheduled testing, not daily symptom screening, uncovered cases. So I think, Susie, I'm not sure that we can comment on the study about Marines because the prevalence is higher in the U.S. than it is here. But if you could talk about surveillance testing.
Yes, sure. And where the risk is higher and there are individuals who might be exposed unknowingly, and it's harder to maintain physical distancing and actually have good adherence to some of these strict measures as they're outlined here. Surveillance testing sometimes is a useful way to kind of try to identify cases before they become symptomatic or that are asymptomatic. So there are definitely times when it's important to be doing asymptomatic surveillance type testing. Another good example would be if we have a unit here in the hospital under outbreak, we do regular surveillance testing to see if we can identify new cases before they would otherwise come to our attention. I do agree symptom screening is not going to uncover all cases. We know that. It is still an important component because it does help us to identify some individuals in between when you would do any kind of surveillance testing when you're dealing with an outbreak, for example, or even just in general, but it's not the be-all and end-all to helping us identify things. I guess my one comment would be, where to employ surveillance testing, asymptomatic testing, is always a big challenge because you have to balance what is the utility of it? What are your chances of uncovering cases that are going to be relevant? And what is the lab capacity to do so? And we don't want to impact on the ability to provide testing for those who truly need it and are at high risk. So these are big decisions that need to be made, not in isolation, not just us alone, and has to really take into account what the overall risk is of that population that you would be doing the screening on in order for it to be of value.
Kevin.
Yeah, Susie, I'll just add a couple comments on the point-of-care molecular testing. As you know, many of you have heard about a couple, one called ID Now and the other called PanBio. So through the federal government, the provincial government has received a number of point-of-care antigen tests, And again, thanks to our lab team and our ID team and Susie and her IPAC team, we're looking at where we can best deploy those point-of-care tests. We also have now heard from public health about the equivalency or close to equivalency of a nasopharyngeal swab versus a nose and throat swab. So I think if we will be seeing some evolution of more frequent testing, particularly in the most high-risk environments in the coming weeks. And obviously, antigen testing will be an important part of that. Our laboratory, even though Health Canada's approved those tests, now need to calibrate them and ensure that what they see or claim are efficacious actually bear out. And a number of studies are being done at UHN. I know one in the emergency room looking at what the reliability and validity of those tests are relative to nasopharyngeal swabs and a more traditional state-of-the-art or standard of testing through laboratory processing. So stay tuned on that one. We've received a number of those kits. We just need to make sure that the utilization is both safe and effective and efficacious. We would hate to provide a test result that was incorrect, either in the positive or the negative. And so stay tuned on this one. I think you'll hear more provincially and at UHN.
So the next one is for Tamara. With the rising community cases, how come COVID testing isn't offered on site for staff anymore? For me to book an appointment at TWH to get tested and then spend 30 minutes on public transit to get there and back on my own time isn't the safest option, as it also increases exposure. I think, Tamara, before you answer, I think this also reflects the change in the provincial direction of testing. Tamara.
Yes, absolutely. So early on, we were doing a lot more testing, and we had the Hallowell Center, had multiple redeployed staff, and we were just learning about the illness in the spring. And John can elaborate as well, but what we have learned is that some of that testing may not have been done quite as necessary, and there's been more and more studies to show that, you know, we are good to be testing people who have symptoms. We also don't want people who have symptoms coming into the hospital. So right from the very beginning, we have said, if you have symptoms, you need to stay at home. If you and then you can go to a CAC. At Toronto Western, we do have reserved spots for UHN employees and or their families, but that is a community access center, and there are others around the city, but we do get expedited results from Toronto Western as well as Women's College, Mount Sinai. So it is a good process, and we want to use our internal occupational health resources to ensure that we're doing good contact tracing, following up on exposures, and evaluating what is happening. But we're not doing the asymptomatic testing that we were in the spring, unless it's warranted, as Susie mentioned, for an outbreak, and that's not really asymptomatic testing, it's just surveillance and looking for potential links.
Okay.
I think maybe, Tamara, the other point is obviously this is one that with cases rising, we'll continue to revisit for the individual who submitted it in terms of transportation. While it will take a bit longer for us to get your result, there are surveillance centers set up through all areas of the city. So if there's one closer to your home that you feel would be less risky, then by all means take advantage of that. The second piece, of course, is, as Tamara's reinforced, with symptoms, please do not come to work. If you're at work and develop symptoms, again, report it immediately. But I have a feeling with the kind of numbers that we're talking about, if we don't bend this curve, we will have to revisit testing as a society at a number like 6,500 a day. If that 5% growth rate ensued, we will have to dramatically change how we manage this approach to testing.
Okay.
And thank you. I agree, Kevin. And I think the other thing that we did not have in the spring was pharmacies and other, as Kevin said, there are other places to do testing that we didn't have available to us. So it is available in local pharmacy. I know certainly my family, that's where they went to get tested. And for any sort of asymptomatic testing that you need to go visit a loved one at a nursing home, or if you're a care provider for somebody.
Thank you. Next question, and I think this is for Diana. A valid concern raised by many in public health is that part-time employees with mild symptoms will come to work if they do not get paid. If it is a choice between paying mortgage, feeding your kids, people will come to work. As healthcare leaders, UHN needs to advocate for part-time staff getting paid sick days. So I think this goes back to pandemic pay, Diana.
Yeah, I think this might be a little bit different than the pandemic pay. Jill, I think this may also be talking about that COVID sick pay initiative that the provincial government had earlier during wave one, where we were able to code individuals who wouldn't typically be covered under a sick time policy and pay them through that funding. That is no longer in place, but we have been through the Tasman HR group lobbying to see if we can get that put back in place. The other alternative is I see this in the next question, is the EI CERB, which individuals can apply for.
Yeah.
Okay.
If they're not covered by sick time.
Okay, and the next.
So I just want to say I am certainly advocating, and I know Diana is, and a number of others are saying, you know what, not only for us, frankly, probably less for us, and much more for a person living in a highly endemic area who may be underhoused, who may be working 3 part-time jobs, who really has a challenge in again making ends meet. So there is a lot of advocacy going on around how the province and the federal government might be able to support individuals who choose to have part-time work or have no other alternative. But I want to assure you that there is aggressive advocacy on this point.
Okay. The next question is, again, Diane, about work from home. I think we've been pretty clear about the fact that there is a mechanism that people can use if they don't believe that their manager is dealing with their request.
So if you'd like us to, if this question is, can we ensure that we communicate with all managers that there should be a dialogue with staff about the potential of work from home? Yes, absolutely there can be. I think I'd be surprised if there's a manager here who doesn't get that. But if staff are finding it intimidating, then I can assure you I'll send something out requesting managers and others in leadership roles to ensure that that dialogue occurs with the areas they're responsible for.
Okay, the next question for Diana. I'm still confused about what happens if we have to isolate due to possible external exposure. I assume in the question means that they've been told to isolate, because with contact tracing, you would be told to isolate if it was very close contact. I don't think you can just decide to isolate because something has happened. Are we supposed to continue to come to work if we don't have symptoms? If we are off, we don't get paid. So can we get EI or CERB? Thanks for helping me clarify. Diana.
So I'll answer about the EI and CERB and the paid part. I think that Tamara should probably answer the part about the should I come to work if I don't have symptoms. So with regards to, again, if you are somebody who's had a close exposure at work and has been asked to isolate, yes, you would be paid for that. If in the alternative, you are isolating and you do not have symptoms and you, because you've had a close contact in the community, then that would not be covered under our sick leave plan. But EI, CERB is a possibility for you. I think since we're getting so many questions, what I can commit to do is putting some information on the HR website about EI CERB for easy access.
Okay, Tamara, do you have anything?
And Tamara, I don't know if you want to answer the part about the being asymptomatic.
Sure. I think each case is very different, and I would advise you to take a look at the toolkit. It has several different scenarios broken out into it. So there is a difference if you've had direct contact with a close family member or colleague, and you've been you've been together for 15 minutes with mask, without mask, etc. So there's a large ratio of who is excluded from work and who stays, or if you're a contact of a contact. If in doubt, always feel free to contact the hotline, but there are some guides within the COVID toolkit that could help you describe your specific situation. But again, if you have any symptoms or you're in doubt, please call. Definitely, if you have any symptoms, do not come to work. And if you're in doubt, please contact the COVID hotline and we will return your call and do an assessment on your individual situation.
So the next one I'm going to give to you, Kevin, because I think it's respect and civility. Many staff members argue with screeners when asked to show their badges when entering the hospital. Common complaints heard: how dare you ask me? I've worked here for 25 or 30 years. Or, are you security? Or, I don't have to show you my badge. This behavior is unacceptable and a statement is required.
Yeah, I'm astounded that anyone who works here would say that. So it is completely unacceptable and it's offensive. So you're not living by the code or the values of UHN if you'd respond to someone. And if you find it difficult to show your badge, which you need to be wearing to enter the building, then maybe you don't want to work at UHN anymore. I'm sorry to be so blunt, but if you could actually be that rude to a colleague who's been deployed to do screening, you don't appreciate working here, and it is a privilege for all of us to work here. It's a great place to work. If you can't live up to that minor standard, I suggest you really strongly consider whether you want to be part of Team UHN. It's unacceptable, and it will not be tolerated.
Okay, that's a statement.
That's a very strong statement. You should expect disciplinary action, followed by up to and including termination. I have zero tolerance for this. If you actually think it's hard to show your badge to someone who's trying to protect you and our patients, you are grossly underestimating the value of working at UHN.
Okay, the next question. I don't think Rebecca's on the line. Can you please explain why staff have to pay more than visitors for 10-day parking pass, $160 versus $127.50? Maybe Ron Swale. Typically, with most organizations, it's the other way around. Thanks. Ron.
Thank you, Jill. First, I want to assure listeners that UHN parking practices are consistent with our peer hospital organizations. And it is true that some patients are afforded a discounted daily rate if they qualify. And that is a result of a Ministry of Health directive to help patients who have to come to the hospital frequently and incur parking costs. And that discounted 10-day rate is $127.50. As noted, or for 10 days, it comes to $12.75 per day. However, the vast majority of UHN's patients and visitors, over 95%, pay the full daily rate of $25.50, which is much higher than the daily staff rate of $16. And also, I want to assure everyone that at this point in time, due to the activity at the hospital, we couldn't handle any more capacity, even if we could give a staff discounted rate. Our staff lots are presently at capacity. Thank you.
Thanks, Ron. It's, the other thing is we're in central Toronto, and parking downtown in central Toronto is very expensive. And if you lowered the rate, you'd have a lot more people wanting to park, and we don't have the space.
Absolutely.
Next one, I think we've answered because it's about working from home. So we'll go to the next one after that. Inpatient nursing units are being bombarded with over 100 phone calls a day about visitor policies. Please create one telephone number for family members to call to inquire about visiting, like a family support line. The unit staff and nurses are very, very busy as it is. Kevin, do you want to talk a bit about this?
Yeah, so, we've considered this one, and I'm certainly open to continuing to consider it. I think the challenge is we'll probably double the number of calls, because most people who are calling about the family caregiver's arrival also want a clinical update on their patient. So they want to speak to the point of care nursing provider or other healthcare provider involved with their loved one. I also think we also have to be mindful of, we made a choice, back to our previous discussion about what are our values, and our values we chose are the needs of the patient and their family come first. And so for sure we can go back and look at this. We can also direct a lot more people to the webpage, and then think about whether there's a better way when patients do want to speak to a point of care provider to get an update on the clinical status of their loved one. That will, I'm sure, continue to need to occur. As a matter of fact, I think that will expand especially if we see more and more limited access to the building. So for sure, let us take this one back and try to strike a healthy balance.
Next one, with recent vaccine news, has there been any planning at UHN for distribution and prioritization of doses? Maybe, Kevin, you want to answer.
So we unfortunately don't get that luxury of making that plan individually. Maybe that's a good thing, actually, rather than a bad. Obviously, the order for vaccines in Canada has done really well relative to population. We're the largest ordering country in the world, population-based. And part of that, I think, will be Canada's commitment to help other countries who might not be economically advantaged enough to either afford or get the vaccine early. Once received by the federal government, there is a plan being worked out between the federal government and the provinces. And then Ontario Health is identifying hub hospitals, UHN would be one, for the distribution of the vaccine. As you know, in the case of one known vaccine so far, it requires intense freezing at minus 70 degrees centigrade. The latest other one, the Moderna vaccine, doesn't require this. I was educated today because of the lipid bilayer. Thank you, Brad, and Twitter. But that being the case, obviously, we want to make sure there's a very robust distribution mechanism, as well as a very clear who gets this first. And so another part of our advocacy with government is now, not when the vaccine arrives, we need to make a very clear statement about how distribution will occur, who will be first in line to get it, if we have limited supply, how will we make those decisions, and of course our ethicists need to be deeply involved in this discussion as they would always be at UHN. So this one is something that will be a provincial and federal decision, but UHN will be actively involved in managing its distribution. And obviously in advocating for those most at risk, including healthcare providers, to be early in the inoculation chain.
So the next question is our last one. It's addressed to Susie Hoda. I think, John Granton, if you're still on the line, you may be seeing patients who have recovered from COVID-19. So the question is about the recovery from COVID-19. What do we know about the long-term side effects? So Susie or John?
I guess I can get started with it. I think the bottom line is we don't know nearly enough about what the long-term side effects are of having been infected with COVID-19. Even for those who have mild or moderate illnesses that recover within a couple of weeks of having the initial infection, we do know that a small number of people will go on to continue to have some health effects, which can range anywhere from chronic headaches or fatigue, weakness, to neurological issues, things like that down the road. So I think that this is an area that we have to continue to learn about, and I'm glad the question was asked because quite often people focused on the risk of hospitalization, the risk of death related to COVID-19, and kind of dismiss the fact that, if you have a mild illness, you're going to recover and everything's going to be fine, and that might not be the full picture of what we're going to have to deal with all those other infections.
Okay, John, anything to add?
Yeah. I would add to that. Yeah, that's excellent. I think just shouting out to investigators here, Angela Chung and Dr. Margaret Harridge, looking at outpatient and hospitalized ICU patients, respectively, looking at the long-term sequelae of these infections. Again, UHN taking a leadership role in that area and helping us understand how this is going to affect people's lives going forward. So some great work being done locally that will hopefully address that question in a meaningful way.
Thanks, John. So I'm going to turn it to Kevin for closing.
Yep. So as you can see, the QR code is up on the screen as always, and I want to thank you again for joining us. Please give us some feedback on today's meeting. I know the theme of many of the questions today are not on Lake Wave 1, which I know are also rooted in anxiety and to some degree fear about this illness as it continues to ramp up. Want to remind you that we are here for you if you have anxiety or if mental health and addiction issues come to the fore, and you all know that there are good ways to access those at UHN. It is a very stressful time, and I think many of us believe it'll get more stressful in the coming weeks before and until we see people changing behavior and the number of positive cases going down as well as the number of cases requiring hospitalization. In addition, please have a look at the on the screen. You'll see the open forum frequently asked questions, the occupational health toolkit, human resource information, and as I mentioned, mental health resources. Nothing is more important to us than Team UHN's well-being. Thank you all for what you're doing. Stay safe, and please be respectful to one another. Thank you.